And I'm very pleased to introduce the next speaker, that is Melanie Konigshoff, that will talk about airway and lung remodeling in idiopathic pulmonary fibrosis. Melanie.
Okay. Thank you very much. Can you hear me? Yes. So first of all, thank you very much for the kind introduction, Marina, and I would also like to thank Leo for giving us the opportunity to talk to you today here in this meeting about idiopathic pulmonary fibrosis and specifically about airway and lung remodeling in IPF. And I believe that this is the first talk about IPF in this setting today, but this will be not the last one, so I hope I can set the stage for you. First of all, let me quickly introduce to you to the disease, which is idiopathic pulmonary fibrosis, which is a progressive and fatal interstitial lung disease. And this is a median survival time about 3 to 5 years. And most importantly, we only really have very limited therapeutic options. The prevalence and incidence of this disease is on the rise, and we get actually newer numbers day by day. And if you just look at the left-hand side here on the histology for the first time, you really can see what's wrong with these lungs. On the upper part, you really see the normal lung architecture with the normal alveolar and the normal gas exchange area, and you can see that over here what happens in pulmonary fibrosis is that it leads to an increased deposition of ECM, meaning that we have a total distortion of the whole lung architecture and thereby also, of course, of lung function. So I would like to talk to you a little bit more about now the pathomechanisms which we think about are lying the basis for this. So on the left-hand side here again, now you see the similar architecture and histology, but this is now out of the animal model which we normally use for idiopathic pulmonary fibrosis, which is the bleomycin model. So again, you can see here the fibroblast deposition, and what we believe what normally happens is that we do have an initial repetitive injury of an alveolar epithelium, so this seems to be the major target in pulmonary fibrosis, and that this leads then to alterations in the epithelium by itself, but also to myofibroblast activation and increased extracellular matrix deposition. On the next slide, this is again showing a little bit the overall idea about the pathomechanisms of IPF. What I really would like to point out at this beginning is that there are two major cell types that we are looking at. On the one hand, the big alveolar epithelial cells here at the moment and the quite smaller fibroblast, which is, for my purpose of my talk, quite good because I really would like to focus on the alveolar epithelial cells, and I really would like to show you what we believe happens to alveolar epithelial cells and how they contribute to tissue remodeling. So you see alveolar epithelial cells, as highlighted here in this very nice review, they do seem to have a different susceptibility and a different genetic modification already from the beginning on, which makes them susceptible for IPF. But then they also can secrete a lot of different growth factors, and I will later on show you some data to this. And also they have these growth factors then really have an action on fibroblasts, leading to myofibroblast proliferation, also ECM deposition. So the main questions actually in the pathomechanisms of IPF, which I would like to talk to you today, is which cells are involved, and I already pointed to the epithelial cells already, and what is the source of the cellular plasticity. The second would be the kind of signaling pathways which we believe are dysregulated in IPF, and we can also target for therapeutic intervention. And the last point, I hope I will still have time for that later on, is the footprints in the matrix, because this is really a topic which came up recently a lot in IPF, that really also the matrix is not only something which is a waste from a fibroblast, but really is something which dictates and also contributes to IPF initiation, but also progression. So let me start with the first part, and this is actually which cells are really involved in here, and I would like to concentrate on the alveolar epithelial cells. And I would like to give you several reasons for that. So first of all, this is actually pointing out the classical approach or progression of an IPF patient. And you see that there are several different IPF progressions. That is actually the clinical dilemma that we are in, that we don't know who is a rapid progressor or who is a slow progressor. And this is also something I will come back later on again. What I would like to focus here is, so to give you the highlight over here, is that there are initial micro-injuries, and you can see that there are several genetic predispositions predispositions and susceptibilities described, and these are quite often specific genes which are in alveolar or airway epithelial cells. So airway epithelial MAC5B, quite recent one, and here also the surfactant proteins have often SNPs, so have genetic modifications, and thereby maybe cause also disease initiation. And again, this is also showing very nicely why epithelial cells are so important, because if you just look on the left-hand side here, this is just a scheme of the normal architecture of the lung, and you see it's very epithelial cell rich. And if you look at the right-hand side, you see there are not so many epithelial cells anymore, but a lot of fibroblasts. So the main question, of course, always is, where do all these fibroblasts come from, and what happens to our epithelial cells? And this is actually showing you what happens in terms of the alveolar and airway region now in IPF in terms of remodeling. I hope you can appreciate this and see this here on the left-hand side. There's a small airway, and you see in green smooth muscle actin, somehow a mesenchyme marker showing you where remodeling happened. And you also see that this SMA staining is not restricted anymore as we have it normally in a healthy lung, but that you also have unrestricted staining, showing you that you have bronchial remodeling also in an IPF patient, or in this case here, this is the animal model. And also in the alveolar region, you also have SMA positive cells, so also showing you that we have tissue remodeling in the periphery of the lung. So the area of airway and bronchial phenotypes and actually all airway remodeling was actually the main part of the talks also that have just opened up the session, but actually this is an area which has more or less been neglected for a long time in IPF. And it has been just recently been highlighted again, because there's a landmark study done by the Denver group by David Schwartz showing that MAC5B polymorphisms are regulated or are present in IPF lungs. And this actually brought the attention back to the bronchial and also to the small airways and to MAC5B expressing cells. And I also only would like to highlight here two studies which have recently been studied, which really show nicely that there's also bronchialization and also bronchial tissue remodeling going on in IPF patients. The first one is also, I have bring here a picture along here. You can see that some pathways, and this is not important at this stage now which pathways these are, but you see that there are some pathways, and this is a staining for several specific proteins in adjacent cells, showing you that these pathways actually do lead to the expression of MAC5B, which then probably leads to bronchial analyzation in IPF patients. This is a very nice study from Bruno Castagni over here. And then a second one, actually also from the Denver group, showed that if you just look at ciliated genes, and we have ciliated genes in our bronchial and small airway, and you somehow try to subtype IPF, you see that you really have a subtype where you have ciliated genes differentially regulated, and that these also then correlate to honeycombing, which is also a very profound sign of IPF. As I said, much more actually has really been done in terms of tissue remodeling when you look on the alveolar region and on alveolar epithelial cells, and this is just to highlight for you which kind of different cells do we have out from the distal bronchial. Then we have mainly focusing here on the type 2 and type 1 alveolar epithelial cells, as these are the main cells that outline our alveolar. And here you actually can see what can happen to these cells if they are sick. So I think always, I really like this picture because it really shows you what kind of plasticities these alveolar epithelial cells have. What you can actually see is epithelial cells on a plastic dish, and they are cultured and then stained for several markers. The one is an epithelial cell marker, which you can nicely see hopefully here in red, which is outlining nicely the alveolar the epithelial structure. And then you also see SMA, which is a marker, as I said, smooth muscle actin, a mesenchymal marker, which is also expressed by these cells. And that's something, if you have a little bit time and can look at this picture, you see cells which are only have epithelial cell phenotype, some have both, have epithelial mesenchymal phenotype, and others already only have mesenchymal proteins expressed, which just underlines the huge plasticity which these cells have, and this might also contribute to fibrosis. This is actually the concept behind its epithelial mesenchymal transition, which is a mechanism which is highly discussed in IPF. But just in general, you can see that alveolar epithelial cells here, shown on the left-hand side, which have normally the nice cobblestone structure, can also then develop due to several steps to a mesenchymal phenotype, to a mesenchymal cell. And mainly TGF-beta have been lately actually described a role in this process. And I would like to show you next some evidence that we have, and maybe also some existing evidence that we have that EMT also may happen in idiopathic pulmonary fibrosis and contributing to tissue remodeling. So what I think is important is that if you look at EMT, and also what has been highlighted by Professor Joost just before, is that we always have to look also at the human disease. So on the left-hand side here, you see the IPF lung, and you see actually very closely again a mesenchymal marker and an epithelial marker co-localizing in an IPF lung, which actually suggests that you have an epithelial cell with a huge plasticity, which also can undergo mesenchymal epithelial to mesenchymal transition, which is seen over here. Of course, it's not so easy to really catch this because it is a very dynamic process, and we just normally have our lungs out of an explanted patient, and we have the explanted tissue, so we have one time point and one area we can look at. But at least you see that this is actually something which can happen. But what we do not know at the moment is really if this has anything really in terms of relevance for disease progression, or if this is even druggable and thereby helps our patients. On the left-hand side, there is an animal model study, again showing this, and brings a little bit more quantification into the place because we can lineage trace these cells. We can follow up specifically our epithelial cells and look if they become mesenchymal. And actually, nowadays, the numbers are around at 5 to 10% actually of these cells, which are normally SMA, so mesenchymal origins in our lungs, can be come from epithelial cells. So it goes without saying, this is a hot topic and somehow debated field. So there are also some evidence in the literature, or actually some reports that cannot find any evidence of EMT. So I just would like to highlight this, of course, as well. Again, similar techniques. We have lineage traced animals and then try to see if we can find any mesenchymal proteins. And in this study, this has not been shown. But if you just follow up the whole, area about where these fibroblasts really do come from, then there is actually a whole lot amount of different kind of origins which we believe might contribute to fibrosis development. And this might not be only restricted to IPF, but can as well play a role in airway remodeling in other contexts such as COPD or asthma. So I would then go on with the second part, which is more about the signaling pathways which are responsible then for tissue remodeling and also in part for EMT. And actually, this was really something which, for a long time, TGF-beta was the main growth factor, which really many people have looked at. And then, like 10 years ago, really microarray studies, and this was actually pioneered by Naftali Kaminski, mainly in the IPF lung, really showed that there are a lot of different pathways activated. And this is just the classical heat map from classical microarray screens. And what you can see is actually that we by now know a lot of different kind of pathways which seems to be active and which have an influence not only on the pathogenesis but also on progression and maybe also serve as biomarkers. So TGF-beta we know already for a long time. I will talk a little bit more about developmental pathways and Wnt signaling. MMPs, there has been reported also to serve as important biomarker for disease. And EMT I just have already been alluded to. And if you just look a little bit closer and see if this really has also been clinically relevant, there have been several studies really showing, as I just mentioned, that this not only shows us pathogenesis in which pathways, but really tells us also in different patients how the disease maybe progresses and how the disease develops. So we have information also about disease progression outcome, and maybe also some of these markers really can then follow up on biomarkers, and there are a lot of different studies at the moment going on to prove this further. So actually, one of the main developmental pathways which is activated in IPF is the Wnt beta-catenin pathway, and I would like to show you a little bit more data about this. And just quickly remind you or introduce to you the pathway and how it looked like. So Wnt ligands are proteoglycans. They are secreted proteins which bind to receptors, which you can see over here, like frizzled and LRP receptors. And what is important to know is, first of all, that these are ligands, and we have several of these ligands. So there are 19 different ligands, but all of them have the same area actually of action. So they bind to their receptors, and then many of them activate beta-catenin. So this is why it's called the Wnt beta-catenin pathway, because beta-catenin is the main intracellular signaling mediator of this disease. So everything what I will talk to you now from now on will be related to Wnt and mainly also to beta-catenin signaling in disease. And you see already, so this pathway is very much known to be important for lung development in general and also for stem cell homeostasis, mainly known from the gut and also from the skin. But now it's also more and more shown that also in the lung we really have a phenotype if we don't have appropriate Wnt signaling. So the big question is always what went wrong now. If wind is normally so good in development, why does it something wrong in an IPF lung? And first of all, here's the first evidence actually that really the wind beta-catenin pathway is differently activated. This is by an Italian group, by Marco Celosi from Verona, actually for the first time really showing that we have beta-catenin as a main mediator, as a surrogate marker in IPF lungs, which is really in alveolar epithelial cells, as you can nicely see over here, but also in fibroblast foci, showing you that both cell types actually respond to wind signaling and activate this pathway. We have then also done similar studies where we could show that a specific wind target gene is upregulated in IPF. This is WIS1, which is shown over here. It's very specifically upregulated by alveolar epithelial cells, and you can also see that it localizes here to the classical hyperplastic alveolar epithelial cells. So the alveolar epithelial cell is a very, very rich source of proteins which then can contribute to tissue remodeling. In terms of wind signaling, we also have then confirmed these studies and looked a little bit further on this, and this is again just another data set which confirms that different wind proteins are activated and also that beta-catenin is activated, and I hope you can nicely see this over here. And I brought this slide actually with me to show you that this is a somehow normal looking area in an IPF lung because it's very heterogeneous, and even in the normal looking areas of the fibrotic alveolar septa we already have nuclear beta-catenin which places somehow this pathway and the activation pathway also at the very beginning of disease progression. So this is then actually the summarizing data on all what we know about now from wind beta-catenin. So we knew it's activated, and we could have shown that not only that there is a classical really wind signature in an IPF lung, which is distinguishing IPF from other interstitial lung disease, but this is also amenable for therapy. So there have been now several studies showing that you can inhibit wind beta-catenin signaling on different levels, and they will also attenuate pulmonary fibrosis. There is, however, also some data which actually really tell us that it's not only up and down and black and white, and that we really have to look forward on, because beta-catenin by itself also has been shown to be very survival and very protective for an alveolar epithelial cell. And I just would like to share one data here with you in this respect, which actually shows you that if you take type 2 cells, normal ones, which have no genetic susceptibility or anything for IPF, just normal cells, and then you treat them, and over time you could see actually that in this case beta-catenin does something good, because we can see that we have a type 2 to type 1 cell differentiation. I think here you can see it very nicely. Active beta-catenin comes up during the time course, and during this time course normally in culture type 2 cells become type 1 cells. So there is something else behind, and we have to think about how we can place this all together. So of course there are several ideas. One is that we have a different capacity of the IPF epithelial cells. I alluded to that already, that they have maybe different mutations, different genetic susceptibility. They can't really respond to wind signaling. And then, of course, the other major cell types, the fibroblasts, which we have in IPF, also responds to wind signaling, and there have been already several studies showing that this leads to a myofibroblast differentiation, so clearly also to tissue remodeling. And what we also have to take in mind is that we have growth factor crosstalk, and to this I would like to show you 2 more data slides now. I will skip this, because I think this is very important. If you just look on the developmental signaling pathways, we not only have wind, we not only have TGF-beta, it's very clear that we have a multitude of different pathways which seems to be aberrantly regulated in IPF now, and we have to find if we have a common target to go for. So in talking about beta-catenin does normally something good. Why can beta-catenin or wind signaling does something bad in IPF? This is one kind of evidence for here, a study again in the human tissue in IPF lungs done, where you can see a transcriptional regulator of TGF-beta signaling, which is SMED3, combined with beta-catenin, that these co-localize in a cell, and that this drives beta-catenin in a different direction. So in this study, actually, this is done by Zia Borg's group from LA, they showed that these cells, if we have co-localization of beta-catenin and SMED3, that this drives a more fibrotic phenotype and not a healthy survival. And there's data down here also providing evidence that WIS1, which I just showed to you, which is a classical wind target gene, and if we inhibit this target gene, we could also reverse fibrosis. But this target gene is not only produced by wind beta-catenin signaling, but it's also induced by TGF-beta. So we have common pathways which all have probably similar downstream targets, which we further have to identify, which we then can target for therapy. Okay, and the last part, which I would like to point on now, is the footprints in the matrix. As I just said at the beginning already, we do have a lot of different concepts over the years in IPF, coming from inflammation to epithelial cell injury, and now really many data recently have been published in terms of the role of really the matrix and what is the role of the matrix by itself. And this is just a recent paper, I think, published just a few weeks ago in JCI by John Bitterman's group and Eric White, where they really could show using an IPF lung, they decellularized this IPF lung, so they just looked at the pure matrix, and they could show that this matrix really dictated fibroblasts and epithelial cells in a profibrotic direction. They could even override really the normal healthy phenotype, so which really shows you that the matrix by itself has a positive forward loop, how they also call it here in the title, but really also dictates progression in this disease, and so thereby also is a very important target for future therapies. So what has this all to do with epithelial cells? And of course I would like to come back with this in a last data slide that I have with me today, is that there always have been a huge discussion that fibroblasts are main producers of ECM and also main producers and main contributors to tissue remodeling. But there have been actually very nice data now out that also show that alveolar epithelial cells also can really produce ECM proteins, also mesenchymal proteins. Here you can find a list like SMA, tenascin, collagen, even collagen 1 is produced by fibrotic type 2 cells. And this is a very elegant study actually shown over here, where they specifically deleted this collagen out of an alveolar epithelial cells, and you could actually see what really also the alveolar cells in terms of tissue remodeling contribute to the disease. And you can see, if you just look at this Western blot, here's a lot more collagen, here's less collagen. So the difference which you can see here is the collagen which is missing from type 2 cells, which shows you that also alveolar epithelial cells as well as fibroblasts both contribute extracellular matrix and thereby actually contribute to tissue remodeling. And with this, I would like to actually come to my take-home messages, and I hope I'm in time, and maybe we have some time left over even. So the first is that I would like to point out that airway epithelial cells, and specifically also alveolar epithelial cells, exhibit an altered fibrotic phenotype in IPF. The airway epithelial cells, in terms of bronchialization, really is something, and honeycombing, which probably will be much more under investigation in the future, and that epithelial cells contribute to tissue remodeling. First, by altered plasticity and function. I alluded on EMT, where the verdict is still out if this really is also druggable for therapy. On the secretion of different growth factors, among others, there are clearly also some others. I highlighted Wind and TGF-beta, where we see crosstalk, and which we have to think about how we can address this. And then also the expression and secretion of mesenchymal proteins and ECM proteins, which really is somehow a dogma change in our thinking, where the ECM production really comes from in IPF. And with this, I would like to sum this all up, and also would like to take home message from the previous speaker about translational research. So what is all of this if we cannot translate this into the human tissue? And if I would have shown this nice scheme where you can see here epithelial cells, or in general progenitor cells, play a different important role, signaling pathways and the matrix, what can we do with all of these? And over the last 6 to 8 years, I would say we really had made major advances in IPF, because, as I said, this would have been blank like a few years ago, and now we at least have several clinical studies also in IPF, which are mainly coming out from the recent findings I showed you already. And I hope I, with this, also can set the stage for the next session where we talk about targeted therapy also in IPF, and I actually look very much forward to this. And with this, I would like to thank you for your attention, and I hope I see many of you at the ERS in Munich, which is a hometown for me now since 4 years, because we have the ERS in Munich. And with this, welcome to Munich then again over the Alps, and thank you for your attention.
Thank you very much, Melanie. We will come for sure to Munich to visit you. And thank you for the lecture, showing how complicated it is, this disease, not only in humans and in models and in vitro studies. So we have time for a couple of questions. Somebody has? Paola, Professor Rotoli.
So thank you for the wonderful lecture. Do you think that the modulation of Wind's pathway would be in the future a target for therapy? Because there are data on experimental animals.
Yes. So, yeah, actually the verdict is out. So there are some promising preclinical studies by now, and also with the ICG 001, which is a beta-catenin inhibitor. There are already some clinical targets. And I think in general, it's worth to go for it, because in another disease, like in cancer, there have been studies showing if you specifically block Wnt receptors, for example, that you can also really have an effect on disease progression. So we know a little bit that in general it's safe, and now we have to see if it's also really working in the human tissue, yeah.
Sorry, I had a question myself.
Thank you for your presentation. Very interesting, and a lot of things to learn. One of the things that I'm very interested about is that it seems that it's well accepted now that smoking is the main risk factor for fibrosis. We have been looking at fibrosis, and we have a fairly good population, and then looking at the literature also, we find that the smokers who develop fibrosis do not have COPD. Yeah. I mean, are the ones who do not develop COPD, yes. But they develop fibrosis. But we also know that the people who develop COPD, who do not develop COPD that smoke, they injure and repair, and constantly repairing. So tell me, how can we explain that? I mean, why do some go one way, some go the other way?
Yeah, no, yeah, a very good question, actually. I was just starting to think about this because you were mentioning we should also, really look at younger smokers and see which of them and why do they develop fibrosis or COPD or something else. I just have to say, I think at the moment we don't know. There is nothing which we could say directly, which we have that we can, predict this. If you just look at the data from the genetic susceptibility and from the mutation, there seems to be clearly differences that we do have mutations and SNPs in an IPF populations which we can't find so much in COPD. But this, of course, would maybe just, give a different threshold. Maybe this is really the case. But why then these diseases develop so differently? Yeah, that's, I think, something. It's a very good question, and I believe that we will stuck on this for the next 5 to 10 years at least.
Bye-bye.
Sorry, just one little question for my curiosity. As you said before, I think in lung tissue we can find some markers of the progression of the disease. So is it possible that the acute exacerbations are the same as the rapid progressors? Meaning the acute exacerbation can be a slow progressor that becomes rapid, yeah. or they're two different accelerated?
Yeah. So I think this is actually something which we can't really distinguish at the moment. Okay. Yeah, so therefore we really need more of these biomarker studies and really have also a high enough cohort actually to really be able to distinguish these. Because that's classically our problem, that the numbers are not so high that we can really distinguish these different phenotypes as well. Yeah.
Thank you very much for your